Good evening, dear students. If you see presentation and hear my voice, just tell me. I'm waiting for answer. Hi, anybody. Do you see presentation and hear my voice?
Hello. Yes, yes.
So, good. The lecture is recorded, so you have the opportunity to see for several times.
Okay. But I have a question. You will be putting the questions for the exam.
No, you just only listen the lecture presentation.
So we need to study from the book or from the PowerPoint you
If
will
you
show.
have any questions, the lecture will be recorded with these PowerPoint slides, which I show now.
Yeah, but I mean, from where
But
we
if you
can
have
study
some
from?
questions, then you can just email, put them on the email.
Okay. Okay. Thank you.
So, today this lecture is dedicated to the diseases of nervous system. But you see, it's just not in such a way as you listen other internal medicine diseases. Because in neuroscience, everything is like the chain, it's based on one each other, and you cannot understand any neurology disease if you did not know the basic things of neuroanatomy and neurophysiology. As I told you are in future became the students of stomatology school, and according to this, I try to point on the things which are necessary for you in future. You know that the teeth are innervated by plexuses, which are formed by the branches of the trigeminal nerve. But before we come to concrete to this cranial nerve, let's discuss generally what functions has the nervous system and how the nerves, peripheral nerves, cranial nerves are formed, because without this knowledge, it's very difficult to understand the diseases. So step by step today during these 2 hours, I understand that it is very short period of time for such discussion, but let's try our best. As you see on this slide, here is the example of main function of the nervous system. Main function of the nervous system is the nervous activity, which is the same as reflex activity, because everything we do by the help, by the aid of the nervous system depends on various reflexes. Some information are detected by our receptors. Never mind what type of receptors it is, mechanical or distance receptors, like the hearing the sound waves or see some object like the light waves. Then it's transformed, it's detected in the receptor and transferred to the nerve impulse. And then this information is processing to the definite parts of the central nervous system. And according to this, created the response. As we say that the main function is the reflex activity, then we must remember that reflex is the response of the organism, response of the organism, not response of nervous system. It's response of our organism to internal or external stimuli. And nervous system, CNS, helps to make this response to our organ. But here you see another red arrow which goes downstairs. Each information which are processing to our CNS, it also is memorized in our limbic system. For here comes the experience, because when the child is born, he even studies many things at the beginning. The surrounding things are for him unknown, and he is studying them. of what use they are. Even he did not know how to walk. He is studying how to walk, how to speak, and so on. It is also the reflex activity. So all reflexes are divided into groups. It is unconditioned reflexes and conditioned reflexes. You see that unconditioned reflexes, it's like the gift of the God. We were born with this type of reflexes, and during our lifetime, they did not change. They are constant. Till the person, human being, is alive, he has this number of unconditioned reflexes, which did not change. But for survival, for definite purpose, learning, and so studying new skills, he needs other type of reflexes, which are created during the lifetime, and these are conditioned reflexes. They are unconstant, and when necessity in them disappear, they fade. They did not observe no more. So remember that all reflexes are divided in two groups and conditions, which are constants that did not change during our lifetime, and another group reflexes which are established during our lifetime according to necessity. Just to make such a simple ex- example, when you buy new laptop computer, there is some working programs which are working in this computer and make possible to work to the computer till you kill this computer. But according to necessity, we need some other programs which we install, and then we find another more good program. We erase this new installed program and put there another. Like this is example of unconditioned and conditioned reflexes. As we say, everything which done by the nervous system is the reflex activity, and there is no reflex without reflex arc. It is mechanism which is necessary to detect the stimuli, to process then this information and to give the adequate response to it. And this reflex arc, it's very interesting phenomena. You see this person, it is the French scientist. In that period, there are no such measuring doctor, scientist, mathematics, and philosopher, and so on. They all were scientists, and they have knowledge in different branches. This was René Descartes. He was in, as you see, in the 17th century. He was born at the end of the 16th century, but lived and worked in 17th century, who established the term this reflex arc, and he describes five components of the reflex arc. So the first component is the receptor organ, as we say, it detects the stimuli. The stimuli will be of different kind, but this mechanical energy then is transferred in the receptor to electrical signal. This electrical signal is called the nerve impulse. It is electrical charge about plus 30 or 40 millivolts. And then this electrical signal or nerve impulse is delivered to the second component of reflex arc, which is the sensory part. And then it comes to center of the reflex, integrated center. And each reflex, there are thousands of reflexes, but each reflex has specific only for him the integrated center or reflex center. That are of great value because if there is the absence of definite reflex and absence of the reflex we call areflexia, then according to this you can have idea where is the localization of pathological process. For example, the classical example is the knee reflex. The integrated center of the knee reflex are in the um, segments of lumbar 2, lumbar 4. And for example, if on right side there is the absence of this knee reflex, then you understand that spinal cord is damaged on the same side, on the left side, on the level of lumbar 2 or 4 segment. So it allows you to detect localization of pathological process. So it's very important that this information by nerve impulse from the receptor is delivered to integrated center, where is the analyzing of the kind of the information, what stimuli, what irritation gets our organs. And according to this signal, to this nerve impulse, is create the response. But response are made by the muscles or internal organs. So this creating response by motor or descending part or motor nerve is delivered to the effector organ, which may be a skeletal muscle, smooth muscle, or gland. So each reflex has these 5 components, but each component may consist of the chain of hundred of the nails. But the components, these 5 components, are the similar, are common to all types of the reflex. And once more I repeat, that absent of the reflex is, you understand, if any part is damaged, receptor or sensory part or integrated center or descending part or connection with the effector organ, in this case we cannot observe the response or absent, the reflex is absent, which is called areflexia. Decrease of the response is called the hyporeflexia. Increase in some cases, I observed the increased response. It is called the hyperreflexia, but this is the subject of another lecture where is observed hyperreflexia, where observed hyperreflexia. But you must remember that each reflex has the reflex arc. The specific to each reflex is integrated center. They have their own integrated center. It are not only in the spinal cord. It may be in the brainstem. It may be in the cortex. It may be in cerebellum, in basal ganglia, and so on. And of course, you must remember that the effector organ is the peripheral part of this reflex arc, which realizes this response, which is created by nervous system. Now about the few words about the anatomy of the CNS. I hope that from body system 2 you know this description, but once more I want to attach your attention to this. CNS is composed of the brain and spinal cord. About brain we speak a few minutes later, but another part is the spinal cord. And by the structural building, by the function, it's divided to 31 to 32 segments. And according them are 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, or 1 or 2 coccygeal. Some human beings have, some of us have 1 coccygeal, some of us have 2 coccygeal segments. And now what contains each segment? Each segment here see on the picture is composed by anterior or ventral root horn, posterior or dorsal horn, anterior or ventral root, and posterior or dorsal root. According to their functions, there are four types of neurons: motor neurons, sensory neurons, interneurons, which connect these two type of neurons to each other, and also in lateral horns of the spinal cord in thoracic region also situate the vegetative neurons, the neurons which are part of the vegetative autonomic nervous system. As in nervous system, impulses are transmitted from one neuron to another by the axons, so the axons of motor neurons of our anterior horns form the anterior roots. Axons which come from the dorsal ganglia and enter the posterior horns form the posterior root fibers. So, anterior root fibers leave the spinal cord, posterior root fibers or sensory fibers enter the posterior horn. Here you see in the middle part of the spinal cord the butterfly-shaped formation of the gray color. Everything by naked eye, which we see at the section material of the nervous system, is the bodies of the neurons. They have the great appearance, great color, and they are surrounded by the white matter or structures by white color because axons in central and peripheral nervous system are covered by myelin shift. In central nervous system, this myelin is formed by the cells which are called the oligodendrocyte. In peripheral nervous system, myelin is formed by the cells which are called Schwann cells. And the myelin has the white appearance. So when we speak about the white matter, it means the ascending and descending fibers, ascending and descending tracts. When we speak about the gray matter, we memorize that it is the bodies of the nerve. Here you see this appearance on the sectional material, how they look alike on this mm, section. So, as we said, there are these four types of the neurons, and that interneurons make connection between them. Now we come to the more upper stage in CNS, and this is the big brain, which of course has the definite building. And just the prolongation of one of the part of the brain, which is called the medulla, is the spinal cord. But medulla with two other structures, and these structures are peduncles of the brain, which situate in midbrain. Pons or pons varoli and medulla oblongata or just medulla form so-called the brainstem. As we say that the spinal cord has the segmental building, the brainstem also has the segmental building. And the segments of the brainstem are composed by nucleus of the cranial nerves. There are 12 pairs of cranial nerves, but most of them have not one nucleus. One cranial nerve may have two, three, and there are some cranial nerves which have five nucleus. But you know these cranial nerves are paired. So totally they have about, for example, 6 or 10 nucleus. And among them, one of the cranial nerves, which you must know brilliantly because your branch of medicine is based on this cranial nerve, is trigeminal nerve. It has three pair of sensory nucleus and one pair of motor nucleus. So it has not only one nucleus. So except the spinal cord, the segmental building also has the brainstem. As we say that all reflexes have the integrated centers, and that these reflexes are divided to unconditioned reflexes and conditioned reflexes. So all integrated centers of unconditioned reflexes are situated, are localized in the segments of the spinal cord and in the segments of the brainstem. Higher nervous activity, which is associated with the cortex of the big brain, so the reflex centers of the conditioned reflexes are situated in the cortex of the big brain or cortex of the hemispheres. Remember this very important point that reflex centers or integrated centers of all unconditioned reflexes are situated in the segments of the spinal cord and in segments of the brainstem. And conditioned reflexes, their reflex centers are situated in the cortex of the hemispheres of the big brain. So here you see this appearance of this part of the big brain, which is called the brainstem. Here you see this left and right peduncles of the brain, crus cerebri, then the pons, and the medulla. The old name of the medulla also is the bulbus. If we translate from the Latin the word bulbus, it means onion, according to the shape of the onion. So in some books, maybe you find that the medulla has the name of the bulbus. It's necessary to know because there is the tract which comes from the cortex and innervates the motor nucleus of the cranial nerves. And till today, we use the name corticonuclear tract or corticobulbar tract according that they innervate the nucleus situated in the medulla, according to the ancient description of this part. As we say that there are 12 pairs of cranial nerves, but if you pay attention about localization of the nucleus of these cranial nerves, we find that only beginning from cranial nerve 3 in brainstem are observed their nucleus. The cranial nerves, first two cranial nerves, olfactory nerve and optic nerve, they are regarded as the olfactory system and optic system. Cranial nerves also belong to peripheral nervous system, except these two cranial nerves. De jure means that by the law, all these cranial nerves, well, pair belong to peripheral nervous system. But factually, de facto, really, two of these belong to central nervous system, first and second pair, and other 10 pair of cranial nerves, they are just only the peripheral nerves. Except the nucleus of the cranial nerves, in the brainstem are situated many other type of nucleus. For example, red nucleus, substantia nigra, pontine nucleus, olivary nucleus, nucleus of the quadrigeminal plate, and so on. Of course, if you were the students of the medical school, not stomatology school, then you have to study all this nucleus and the tracts which pass this nucleus. So the tracts which exit from this nucleus. But as I say, for you, you have the general information of the nervous system, but the specific knowledge you have according to the innervation and also the structural elements of the trigeminal nerve. And I have to say that trigeminal nerve is one of the complicated nerves among these 12 pairs. So, now according to the classification of these 12 pairs, I advise you to put in your papers. This will enrich your knowledge that these 12 pairs of cranial nerves, according to their functions and building, are divided. Kuamoto. Kuamoto means that it has the motor nucleus, and if we say motor nucleus, they are composed like anterior horns by motor neurons. These are third pair oculomotor nerve, fourth pair trochlear nerve, and sixth pair abducens nerve. These three cranial nerves, 3, 4, and 6, participate in conjugative eye movements. You know that one eye always follows another eye if there is, of course, is not pathology, because according to the pathology, there may be paresis of moving of one eye, which is called ophthalmoplegia, but according to their function and cortical centers, which situated in the frontal lobe by Brodmann, it is the field 8, and also according to innervation by the pontine nucleus, this nucleus of these three cranial nerves, 3, 4, and 6, that both eyes are moving conjugately. Conjugate movement has in all directions, left, right, up, and down. So such are 5 pairs. Who are sensory? It means that these cranial nerves did not have the motor function. They have only the sensory function, and as you understand, their nucleus is composed by the sensory neurons. It is the olfactory nerve, optic nerve second pair, and auditory nerve, which is composed by 2 nerves. It is the vestibular nerve or cochlear nerve. So 8 pair is vestibular cochlear nerve. And 4 pairs are the mixed, like the cranial nerve, which we'll discuss today, the trigeminal nerve, which has S sensory nucleus, S motor nucleus. So are the 3 cranial nerves, facial nerve, glossopharyngeal nerve, and vagus nerve. So, according to their nucleus, they have as the sensory component as the motor component. Now let's discuss about the trigeminal nerve. As I already told you, this is very complicated nerve among these 12 pairs. Maybe 10 pair vagus nerve has more complicated building according to from the name. Vago means to travel, and you cannot find the internal organ or gland and even the big arterial vessels which are not innervated or sympathetic or parasympathetic branches of these 10 cranial nerves. But The trigeminal nerve, also very complicated one. According to their function, trigeminal nerve supplies the sensation of the face, mucous membrane, and other structures of the head. Also, it has the motor function. It supplies and innervates muscles of mastication and contains the proprioceptive fibers. But the sensory root is more big than motor root. Motor root is more smaller, and they are coming out of the pons in the junction with the middle cerebral peduncle. It passes laterally and then joins the Gasserian or semilunar ganglion in Merkel's cave. The Gasserian ganglion has, according to the Austrian neuroscientist Gasser, neuroanatomist, who described in details this ganglion from where begins these three divisions of the cranial nerve. And as it has this motor fibers as a sensory fibers, trigeminal nerve or fifth pair is a mixed nerve. Now there is important notes which you must remember according to specificity of your profession, future profession of course. The cranial nerve fifth gives the three branches according comes its definition trigeminal, which innervate different levels of the face and head. The first branch is ophthalmic nerve, and it's very important to remember that it exists from the skull from a superior orbital fissure. So the first division, orbital ophthalmic nerve, leave the skull through the superior orbital fissure. Another branch or second branch is the maxillary nerve, which exists from the foramen rotundum. And the third branch of the trigeminal nerve is mandibular nerve, which exists through the foramen ovale. You see these three divisions of the trigeminal nerve, and all of them have the definite places from where they leave the skull. There is no common apertura, common place when two branches live together. So three branches and three places where they exit from the skull. Here you see this appearance of trigeminal or Gasserian ganglion, and then these branches are, as you see, are are exiting from this place. As we say that the first branch is ophthalmic branch, it's not very long. The nerve in the duration, not like the other two branches, mandibular and maxillary branches, and it passes through along the lateral wall of the cavernosus sinus. You must remember that cavernosus sinus also pass the second branch of the trigeminal nerve is maxillary nerve. But except this, the cavernosus sinus is passing the oculomotor nerve, ophthalmic abducens nerve, and trochlear nerve. So according to this, you understand, and also internal carotid artery. Inflammatory, you must understand that inflammatory processes in carotid sinus, cavernosus sinus, cause the damage of this nerve. So according to and maxillary and ophthalmic branches of trigeminal is sensory part of this system. So, pathology of the sensory system, somatosensory system, will be accompanied by pathology of innervation of the conjugated eye movement. So we must remember that infection processes, and sometimes this infection of the cavernous sinus may be according to the pyogenic processes uh, affecting the roots of the teeth. So be you must have the knowledge about the structures and about the tracts which are passing the cavernous sinus. Also, you must have idea about the corneal reflex because the sensory part of this corneal reflex or blink reflex as we call is according to the ophthalmic branch of the trigeminal nerve. And one thing which it's important for you to know as you in future became doctors, many doctors even which are working in emergency department doctors cannot normally investigate the blink or corneal reflex. They touch the white, which is the sclera. No, it is not cornea. Cornea is the space around the pupil. You must touch by piece of paper or something other material the space around the pupil, not these white places. But many doctors, even practical doctors, make such a mistake. So according to the touching, this, as we say, the all reflexes has the reflex arch. This stimuli is transmitted by sensory part of the ophthalmic branch of trigeminal nerve to the pontine centers in the brainstem, and from there is created the response, and by branch of the facial nerve, 7 pair, this response is returned and realized by blinking, closing the eye. Second branch is the maxillary nerve or second division, and as we already mentioned, it leaves a skull through the foramen rotundum. This nerve is of a big interest for you because after it crosses the pterygopalatine fossa, it inclines laterward on the back of the maxilla, enters orbit through the inferior orbital fissure. It traverses the infraorbital groove and canal in the floor of the orbit and appears upon the face at the infraorbital foramen. At its termination, nerve lies beneath the quadratus labis superioris and divides into the leash of the branches which spread out upon the side of the nose, the lower eyelid, and the upper lid, joining with the filaments of the facial nerve. It's very important. Here you see that it makes the several plexuses, but before they make the several plexuses, they go through the pterygopalatine ganglion. The main branches, terminal branches of this second division of trigeminal nerve is the zygomatic nerve. Posterior superior alveolar nerve, it is just the nerve which you must know the brilliantly. Greater palatine nerve, nasopalatine nerve. So, all of them make the source of the pain, and you often, according to your profession, and everyday day, you will have such a situation. Then you have to differentiate the neuralgia, which is caused by irritation of the branch of um, trigeminal nerve, or it's the dentalgia, that the reason is the pathology of the teeth. So that's why you must know the places where these branches of second division of trigeminal nerve live and which parts uh, of the face and of the mouth and teeth they innervate. The second branch, the mandibular nerve, not like the first two branches of thalamic and maxillary, it has a sensory fibers as the motor fibers. It means that in this third division are mixed the fibers which begin as from the sensory nucleus as from motor nucleus. And the branches of this sensory part, sensory nucleus which begins, innervates the anterior two-thirds of the tongue, so called the lingual branch. Another root, small root as we say, passes beneath the ganglion and units the sensory root just after it exists from foramen ovale. And it innervates the muscles of the mastication. Now about the nucleus of the trigeminal nerve, as I already mentioned to you, it has four pairs of nuclei. The main sensory nucleus, the spinal nucleus, the mesencephalic nucleus, and the most little one is the motor nucleus. So here you see three nucleus are sensory and just one is the motor nucleus. The principal sensory nucleus of trigeminal nerve. You see the reposition in the brainstem. They are in the area of the pons. But some of this, like the spinal nucleus, it begins from the pons, prolonge in the medulla, and even the caudal part of the nucleus enter the spinal cord. And it has the segmental building, which will return to this. The principal sensory nuclei, the definition is in the name is in the definition. It's responsible for touch and discrimination. Touch, you understand, it's the tactile sensation. And discrimination, to make the difference between 2 points. If you simultaneously um, put 2 points, for example, as example, two fingers, if you put on the face, you just may experience now, put these two fingers on the face, you just understand that simultaneously you feel 2 points. But if the distance will be less than 2 centimeters between these two, your fingers to these 2 points, if you close, put the fingers and put on the face, you cannot feel the 2 points, you feel one. It is normal case. But if there is the pathology and the distance is more than 2 centimeters, but still the person did not discriminate that these are 2 points and not one and feels like 1 point, this is pathology of discrimination sensation, and it is according to the principal sensory nucleus. Then comes the spinal nucleus of trigeminal nerve. As I already said, this long one which begins from the pons and even extend to the spinal cord. It's responsible for pain and temperature stimuli to distinguish cold and warm. Mesenteric nucleus. Mesenteric nucleus is proprioception from mastication muscles. Innervation of the mastication muscles are according to motor nucleus, which result in contraction of this muscle. But sensory innervation of these muscles are from the mesenteric nucleus. Now, very interesting thing which also you may find out during your practical work. And of course, if you remember this picture or this information which I give to you, you will remember all of your life. There are two types of innervation of the head and the face. One is the root type innervation of the face, and another segmental type. Root type is very easy to understand according to this picture, to this slide. It is according to branches of the trigeminal nerve, ophthalmic, maxillary, or mandibular. As you see, according to this innervation, the sensation on the face are divided in three regions: upper, middle, and lower. In segmental innervation, and we say that the spinal nucleus most big, which is responsible for pain and temperature sensation, it has the segmental building. And according to these segments, the innervation is by vertical zones, beginning from nose, then comes orbit and cheeks, and then forehead and lower mandibular. So, by this investigation of the sensation, disturbance of the sensation of the face, you can make the differential diagnosis. The sensation disturbance is according to the divisions, branches of trigeminal nerve, or it is disturbance of the root type, or if you find the vertical zones of absence of sensation, in case you understand that pathology is observed, it damages the definite segments of the nucleus of the spinal nerve, of the spinal nucleus of trigeminal nerve. And as we say, the general sensation of anterior to third of the tongue is produced by the lingual branch of the trigeminal nerve. Also, in innervation, the test, the um, detecting the salt, sweet, sour, bitter is according to the chorda tympani. It is the sensory part of the facial seventh pair, but general sensation onto the third is by trigeminal nerve. The root or posterior one third of the tongue, as taste as general sensation, are by the branches of nine cranial nerve or glossopharyngeal nerve. Now about few words about the motor trigeminal fibers. As we say, it's innervate the muscles of mastication. These are masseter muscle, temporalis, medial and lateral pterygoid muscles, tensor veripalatini, tensor tympani. Pay attention. When it innervates the muscle of the inner structure of the ear, not vestibulocochlear nerves. Fibers innervate the tensor tympani muscle, but it's innervated by trigeminal nerve, which is very important note to know about this. The most complicated condition, which observed according to the pathology cranial nerves generally, is the trigeminal neuralgia. Only one type of headache, which is called the cluster headache, may be more terrible than trigeminal neuralgia. I have such experience that the patients which have the attack of this trigeminal neuralgia even beat the head against the wall. So in such a miserable condition they were according to such a type or severity of the attack. This trigeminal neuralgia has many names, and one of them, the ancient name of this is tic douloureus. It's a distinctive facial pain syndrome, which may be recurrent and chronic. It characterized by unilateral pain following the sensory distribution of cranial nerve. Typically, it is maxillary or mandibular area in 35%. You see, you know such a type of headache, maybe you hear, is migraine, which also is unilateral. But in this case, in classical migraine, it has also the name of ophthalmic migraine attack. In the place of the pain is the supra and infraorbital place involving the orbitals. But here in trigeminal, most often the facial pain is observed in second and third innervation areas of the face. The signs and symptoms are variable. It's the provocation of the attack of the pain, or we call triggers of the pain. It's maybe everything: chewing, talking, smiling, drinking cold or hot fluids, touching, shaving, and so on and so on. Each person who suffers from the trigeminal neuralgia has his own trigger of pain attacks. Localization also is very variable, but commonly it may run along the affected division of the trigeminal nerve. And if you know the place where it leaves the skull and then what duration it has on the face, by pressing the places where this branch comes close to the skull, by pressing at this point, you will find the pain points of trigeminal neuralgia, but you must be very sensitive because it may provocate more severe attack of the pain. In 60% of cases, pain shoots from the corner of the mouth to the angle of the jaw. In 30%, from upper lip or canine teeth to the eye and eyebrow, and then it's spreading to the orbit. And only in 5 cases it involves the ophthalmic branch of the facial nerve. The characteristic of the pain attack is also very variable. It is severe, paroxysmal, or lancinating. It's like feeling of electrical shock in the affected area. It's very terrible for surviving this, like the shocker when you simulate it. Maybe you see in the films. I don't think that you experience this electrical shock by the shocker. It may rises like the crescendos for 20 seconds, then it has the peak and then is descending, but not disappear. But when the attack is finished for some period of time, the patient is relaxed, but is anxious because he is waiting for second attack, and everything may provocate this following attack, even movement of the head, or chewing, or close the mouth, or open the mouth, even doing nothing, but generally, which in normal case did not provocate any pain, in this case may be trigger point of new trigeminal neuralgia attack. There is no specific diagnostic method to find out the reason of trigeminal neuralgia. And there are different methods of the treatment of this neuralgia. But nowadays, there is no, how to say, the adequate treatment of trigeminal neuralgia. In most cases, we use anti-epileptic drugs. Why you use, I'll say in few words, but it's for you will be difficult to understand. There is such structure in the brain which is called the thalamus optic. It is symmetrical paired structure, and it is the gateway of all somatosensory modalities. Only one sensory system, the olfactory system, its system of the first cranial nerve, did not go through nucleus of thalamus optic. All other sensory information is passing from the thalamus optic. And as we say, every stimuli which then are going and realizing according to the processes in CMS, it has two ways. One, to what the organism creates the response, and the other is memorized in the limbic system. So this pain also has the pattern of the memory. And to suppress this memory, we use this anti-epileptic drug. Of course, it's not good for the brain activity, but in this case, we have to suppress this activity, to inhibit this activity. That's why you use anti-epileptic drugs, and even in the dosage of this medicine, of this drug, is 3 or 4 times higher than we use in patients with epilepsy. But if the treatment by the drugs is not successful, and as I say, the pain is very terrible, in this case, we go to the dissection of the branch of the trigeminal nerve. As you say, it has 3 branches, and according to them, it may affect the different parts, and in different parts of the face are observed this attack of the neuralgia. So it was the cranial nerve, trigeminal nerve, in contact with which branches of which mandibular branch and axillary branch, according to making the plexuses that then innervates the teeth of the upper and lower part of the maxillary and mandibular part. You will be in the close contact with these branches, which begins from these plexuses and which innervates the teeth. Now let's begin about Ja, lekcija, mak, lekcija. So, just we'll discuss few diseases to pay attention and to have a definite opinion about the neurological diseases. And the most big problem, as you know, which cause not only invalidization of the persons, but also have the fatal outcome, is the cerebral stroke. Nowadays, of course, not only the revolutionary techniques which are in medicine, I mean the radiologic examination like röntgen computer tomography and MRI scanning, allow to detect the cerebral processes which results in the cerebral stroke. But previously, before the era of this radiological revolution, 15, 20 years ago, the neurologists have a big problem in acute stage to make differentiation between the type of the stroke. It was hemorrhagic or it was ischemic stroke. Because the treatment of these conditions are quite different. Hemorrhagic stroke, it means that according to the bleeding, and there are two main mechanisms how the blood is penetrating in the structures of the nervous system. One is according to the rupture of the wall of the arterial vessel. This in Latin has the name per rexin. So according to rupture, per rexin means according to rupture if we translate from Latin. And most often it's according to the rupture of the aneurysm. Aneurysm is the pathological formation, pathological dilatation of the wall of the artery like the sac. And you see, and maybe you have such experience when you are blowing the air in the balloon. If it became of the big size at one part, the wall of this balloon becomes very thick and then thin and then it's low. So is in the aneurysm. It did not have the strong muscle layer and it's ruptured and the blood is uh, penetrated to different structures of the brain. Another mechanism of the hemorrhagic stroke is perdiapatism, or the wall of the vessel, according to the different processes, toxicity, or according some blood pathology, the wall becomes the permeable for the red cells, and they diffuse from the wall outside the wall, and they absorb these red cells, erythrocytes and thrombocytes, absorb the parenchyma of the brain. This is another mechanism of the hemorrhagic stroke. According to which structures and compartments are filled by the blood, there are different types of hemorrhagic stroke. If the blood is observed between the skull and dura mater, in this case it calls the epidural hemorrhage. I have to refresh your mind and say that the brain and spinal cord are covered by three membranes. It is the dura mater, which are followed by arachnoid mater, and then comes the pia mater. So, if the blood is penetrate to the space between the skull and dura mater. In this case, the type of hemorrhage is called the epidural hemorrhage. And the origin of the blood in this space is arterial blood because, according to the damage or rupture meningeal arteries, which contain and in which are circulating the arterial blood. Another type of hemorrhagic stroke is the subdural hemorrhage. Subdural hemorrhage is the space between the first layer, dura mater, and second layer, arachnoid. And here, the blood is venous because it's according to the rupture of the veins of the brain, or blood is penetrated from venous sinuses. So epidural is of arterial origin, subdural of venous origin. To say the truth, most difficult to put the diagnosis of subdural hemorrhage. In previous years, before the era of radiological examination, it was practically impossible at the beginning to put diagnosis. Never mind, it was beginner neurologist or it was professor or mature clinicist. Because maybe only one symptom, it was the complaint on the headache, which was impossible to release by analgesic. And this headache was unusual. Now you understand what I mean. Maybe person wants to take something from the floor, and when he descends and then arise, he strikes his head at the corner of the table. Just a few seconds he has the pain on the definite part of the skull, and then he did not remember about this incident. And after a few days, and maybe after 1 week, begins the intensive headache, which are very severe. And it's usually, as every of us, when we have headache, take some take analgesic. This analgesic did not give any relax to such a pain. It did not release from the pain. So when he comes to the doctor with this complaint on this severe headache, and doctor asks him if he has some trauma or injury of the skull or head, of course he say no, because he even did not remember. It was not so actual for him. He struck the head only for just a few seconds. He has the feeling of the pain of the bone of the skull. That's all. So he did not remember. In many cases, the patient did not remember. And only the method by which it's possible to do, and by examination neurological, no neurological symptoms at the beginning you cannot find. And this beginning, not only the first or second day from this subarachnoid subdural hemorrhage, it may be after 2 weeks. And only the computer tomography make possible to find the blood between the dura mater and arachnoid membrane. And the treatment is only surgical to remove the blood from this compartment. So it is essential to put the right diagnosis. This is just the case when I did not quarrel with my junior doctors why you sent this patient to the MRI investigation or to the computer tomography. I asked them first to examine the patient and then to send the patient to examination to make CT scan to find out he was thinking right, he was putting the right diagnosis, and it was proved by this paraclinical examination or not. In this case, it is the right step. the only CT scan will give you answer. He has subarachnoid hemorrhage, and according to this, a severe headache, or you must have to find other source. It may be, for example, occlusion, hydrocephaly, and something like this. The other question to what's the reason. But most commonly, unusual severe headache, which is not known by this person, it's for first time, is according to subdural hematoma. And remember that there is the presence of the venous blood. Then comes another type of the hemorrhage, it's subarachnoid hemorrhage. Subarachnoid hemorrhage, you know, and I hope that you remember that between the arachnoid and pia mater is subarachnoid space, which are filled and were circulating cerebrospinal fluid. And before the era of computer tomography, to make evident that it is the subarachnoid hemorrhage, we make the lumbar puncture. But lumbar puncture also we done according to such a infection of the nervous system, which is called meningitis, when the delicate membranes, leptomeninges, and leptomeninges mean the subarachnoid and pia mater together, it has the name leptomeninges. When the infection agent causes the inflammation of these two meninges of the brain. Also, to put the diagnosis of the meningitis is necessary to make the lumbar puncture. Few words about the meningitis. The diagnosis of the meningitis are based on the evidence of three groups of symptoms. As it's infection, and in this case it's the infection of the nervous system, like other infection, types of infection of other internal organs, it has the common symptoms which are common for infection process. It is rising the temperature, body temperature, fever, then also it's to is the common the headache, dizziness, and maybe changes in the peripheral blood. It's the common symptoms of infection disease. Another group of symptoms is specific to the inflammation of the meninges is the meningeal syndromes, which are also of two types, the common symptoms and proper meningeal symptoms. Common is photophobia, is the impaired consciousness. It is the vomiting like the fontaine, which did not have which did not have the origin of the taking the food. So maybe the person did not eat, for example, for several hours, or maybe this day totally, but he has such a vomiting. And we call this the cerebral vomiting. And proper symptoms, meningeal symptoms, it's the stiffness of the neck muscle, stiffness of the neck, which is practically present in all cases of the meningitis, and also Kernick's, Brudzinski's, and other meningeal signs. And third group is most important for the diagnosis of the meningitis is the inflammatory change in cerebrospinal fluid. To find this inflammatory change, of course, you must make the lumbar puncture to examine the cerebrospinal fluid by the needle of Beer. Beer was the doctor who first make this lumbar puncture and create this needle and according to him is named this needle of the puncture, lumbar puncture. But there is one interesting question. If the person has common infection disease symptoms, if he has even the meningeal symptoms. So as I say to you, without examining the cerebrospinal fluid, we cannot put the diagnosis of meningitis. So we find these two groups of symptoms. We are think about the meningitis. We make the lumbar puncture, and the fluid, cerebrospinal fluid, is normal. There is no inflammatory change, no presence of the arising of the protein or number of cells. The concentration of the glucose are normal. So what we have to do in this condition? So it's not meningitis, but this condition, we call them meningismus. So meningitis is inflammation according to the infection agent of the pia mater and subarachnoid or leptomeninges. But irritation, not inflammation, irritation cause these symptoms, meningeal symptoms and infection disease symptoms. And this condition is called meningismus. Most often, meningismus are observed, for example, to say, according to the summertime, I don't mean now the months of some months of pandemic of corona, when in normal case the people go to the seaside and to become to change their skin to the bronze appearance, they stay at the sun during all day. And in the evening, they have a terrible headache, vomiting, and when they go to the hospital to the doctor, they find there the meningeal symptoms. So the doctor thinks that the person has what's happening. The doctor thinks that the person has the meningitis and make the lumbar puncture. So it's example of the meningism and not meningitis.
صاحبي انا
Now,
هنزل على السيارة بس بشكلش تليفوني.
نعم
هم
ماشي.
ردوا لي خبر ماشي هنزل.
quiet. Take off the microphone.
قال نزل اقعد بالسيارة
Switch off.
شغل شغلي لكنه رد علي. حل المشاريع ما بيفوتوا فيها.
Switch off the microphone. Switch off the microphone. Oh my God.
في 300 دليفري لو يوصل الواحد خل شوف.
Switch off the microphone. Stupid. So let's return to subarachnoid hemorrhage. And according to lumbar puncture, it's possible to find that the liquor contains the blood and you can put the diagnosis. Also, also the blood may penetrate to ventricles. You know that there are two paired ventricles and unpaired third and fourth ventricles, so the blood may penetrate there. Also, according to the presence of the blood in the parenchyma is the parenchymal bleeding of the brain matter, and also intracerebral hematoma. So all of these are types of hemorrhagic stroke. So nowadays, by computer tomography, when the person are admitted to the emergency department, we make computer tomography, and he has the symptoms of the stroke, and later now we'll speak what symptoms they have. If we did not find on the CT scans the presence of the blood, we suggest that it is the ischemic stroke. The reason of the ischemic stroke are blockage of the brain or cerebral arteries. And there are several mechanisms of such a blocking. Before we go, let's discuss the common symptoms to what we have to pay the attention. And it's not only for the use of the neurologists. Now, as you know, there is such an institute which is called the family doctors. So, if the person has sudden weakness on one side of the body, sudden numbness, or numbness means like tingling in the limbs on side body, difficulty with speech, sudden loss of vision, particularly on the eye, sudden severe dizziness. In all these cases, you should to consult with the family doctor, and then, of course, if the suspicion will be of the ischemic stroke, you must go as earlier to the hospital as possible, because there are now new technologies when during the 6 hours after manifestation of the symptoms of the stroke, it is possible to release the symptoms in some cases and to decrease the degree of invalidization. And this period of time from zero or beginning of manifestation and symptoms and no more than 6 hours is called the therapeutic window. It's very essential to remember this period of the time. Now, according to the etiology of the ischemic stroke, the first type, the reason of the ischemic stroke, according to this, the blood is not delivered to specific areas of the brain, is the embol. And the source of the embol most often is the pathology of the heart. The embols from the heart then spread to the circulation blood system, and it delivered by the magistral arteries, internal carotid arteries or vertebral arteries to the vessels of the cerebral arteries, and it finds the place or branch of cerebral artery, the diameter of which, caliber of which is less than caliber of the embol. And embol blocked this artery, and you understand that the blood is not delivered to definite structures. And neurons are most egoistic cells of our organism. Practically all other cells and tissues of different systems, cardiac muscles, lungs, liver, renal system, and so on, they all make the storage of nutrients. They use only the quantity what they need. Other nutrients are stored, and they use them. There is the need in them, except neurons. For example, if just in this second neuron needs 100 molecules of glucose and comes instead of 100, 500, it did not make any storage. It used all these molecules, all this amount of nutrients which comes just in that moment. According to this, if there is the disturbance of the blood delivery to definite structures, and these structures, as you understand, are composed from the neurons, after 5 or 8 minutes, these neurons die and observe the necrosis of this tissue. So you understand how important is normal blood circulation in the brain. And according to first mechanism, it is the embols, which most often are from the uh, persons who have the different pathology of the heart, cardiologic problems. This embol causes the blockage of the cerebral artery. Another mechanism is a thrombotic blockage of the artery. You know such process atherosclerosis, according to which on the wall where begins the inflammation and on the wall of the vessel are produced the atherosclerotic plaque. And upon the time on this plaque are adhesion of the red cells, thrombocytes and erythrocytes. And during definite time, the size of this thromb enlarge and totally then after some period it occupies all the space in definite part which begins from formation of the atherosclerotic plaque. It is called the thromb or thrombosis. As you see, embolic origin of ischemic stroke manifests immediately after the blockage after few minutes. The process of thrombosis sometimes lasts during years. So beginning is not such a severe as in embolic stroke, ischemic stroke, in thrombosis. And third mechanism is the obstruction or pathological uh, changes of the magistral arteries. The blood to the brain are delivered by two pairs of magistral arteries. These are internal carotid artery and vertebral arteries. So the distribution of these arteries in different parts of the neck and vertebral arteries begin from the spinal cord, so it goes in definite aperturas between the vertebrae, may be compressed by the process which is called the spondylosis or osteochondrosis. And according to the compression of these arteries, not equal normal quantity of the blood is delivered to the brain structures. So occlusion of these magistral arteries also may cause the ischemic stroke. So embolic stroke, thrombosis, thrombotic scores, and also occlusion of the big magistral arteries. And one disease to which I want also to pay attention because it's a big shame, not only for the doctors, but to the medical students, if they did not help the patient which has the epileptic seizure. So, the epilepsy is the chronic disease of the human being's brain. To begin about the etiology of the pathogenesis what's observed in this disease, I want to make a few remarks for understanding what's happening in this pathology. You know that main function of the main cell of nervous system of the neurons is to generate and then to transform the nerve impulse to another nerve. But without any irritation, without any stimuli, the neuron has the negative charge. It's called the resting potential. It is about minus 70 millivolts. And if irritation or nerve impulse did not come to this neuron, he do nothing. He is relaxed and has his negative potential. So he cannot activate another neuron. When, for example, stimuli or nerve impulse come to the neuron, begins the process which is called the depolarization membrane of the cell. It's open calcisodium channels and positive ions of natri, kalium, and calcium are entering inside the membrane in the neuron. And negative charge, which is caused by the negative chloride ions, which did not move outside the neuron, is changed to the positive charge, about 30 or 40 millivolts. And this charge is called the action potential or nerve impulse, which then is transmitted to another nerve. After this cycle is finished and this charge gone to another neuron, begins the process of repolarization. These positive ions leave the membrane, go outside, and the charge of the neuron return to the negative, minus 70 millivolts, which is the resting potential. This is the normal routine work of the normal nerve. Now what happens in epilepsy? Epilepsy is a result of unprovocated, recurrent hyperreaction of the neurons. So without any provocation, without any stimulus, without any nerve impulses, the neurons begin to fire and to establish the action potential, which then spread to other neurons and activate their work. Of course, it's a normal neuron, and that's why they call the epileptiform neurons. These pathological neurons with pathological manner of the work is called epileptiform neurons. And such a changing to pathological condition of the normal neurons may be trauma, craniocerebral trauma. It may be tumor according to tumor process. It may be according to the cerebral stroke, inflammation of the brain tissue, encephalitis, and many, many other cases it may cause. Upon a time, these pathological epileptic neurons induce to work in this pathologic manner other groups of normal neurons, and they organize into epileptic focus. This may be detected by the investigation, which is called electroencephalography, which detects this pathological activity of the brain. But still, this person did not have the disease epilepsy because he did not have the epileptic seizures. Why it happens? Why he did not? He has the pathological activity, but he did not have the seizures. Why it happens? Because in our nervous system is so-called anti-epileptic system, which are the nucleus of the brainstem, pontine nucleus, nucleus of the cerebellum, nucleus of the thalamus, reticular formation, which suppress this pathological activation and don't allow to spread these pathological uh, impulses to other structures of the cortex and other structures of the brain. But after some time, this system becomes more complicated. This, I mean, the pathological system, and it organized and produced the mirror focuses, epileptic focuses, not in the same side of the brain or hemisphere, but also these mirror focuses, epileptic focuses, are established in the opposite structures of the brain. And according to this, the anti-epileptic system cannot manage to block, to stop this impulsation, pathological impulsation. And clinically, it manifested by epileptic seizures, and means that the person has the disease which is called epilepsy. And one more thing, I want to describe your big epileptic seizure, and they say that it is a big shame not to help such a patient. The big epileptic seizure begins with aura. If we translate the word aura from the Latin, it means the blow of the wind. Why the blow of the wind? Why it gets the name of aura? Because this patient with the epilepsy, and each person with epilepsy has specific only for him aura. For one, it is he hears some voice. For another, it is stretching some muscle. For another, it's the flashing light, and so on, so on. He understands that now he will become sick, but it is milliseconds. He did not prefer. For example, he's standing on the steps or upstairs. He did not have the time to descend down. Because after aura in this millisecond, he understands that now he became sick, is followed by loss of consciousness, and the person fall down. He lost the consciousness. After this begin the first phase of big generalized epileptic seizure. It is the tonic seizures, when he has the flexure contractors and he is yawning with all bodies. His muscles are stretching. It lasts about 10 seconds, no more 10 seconds. It's very important the duration of each period of this attack. Then tonic spasm of the muscles is followed by the clonic seizures. Clonic seizures is rapid convulsions, stretch and relaxation of the muscles, and such a feeling you have when you're looking at such a person, that it is shaking, trembling with all his body and with his limbs. It lasts no more 2 minutes. And after this comes the period of rehabilitation. Aura, loss of consciousness, tonic and clonic seizure has the name of ictal period. Ictus means attack, which is followed by period of rehabilitation, which is called post-ictal period, which lasts from 5 to 15 minutes. And this period when the consciousness return and the vital function we mean the respiratory system and cardiovascular system come to the normal. This is the big epileptic seizure. What can you do in this case if such a use is? First, to put this patient, he is on the ground, far from the subjects, because in the clonic stage he may beat his hand and his limb to some subjects which are surrounded. To release and to make possible the air to come directly to his respiratory system. Don't try to take the tongue from his mouth, because there is such a big tension that even if you put the finger in his mouth, he will cut you. But if it's possible, we can put some subject with a handkerchief to his mouth, but not try to release his tongue or open his mouth by your fingers. It's dangerous. And if it's possible, take your coat or something, soft subject, and put under his head, and make possible not to injury. This is the first step. If he is lucky and nearby is the drugstore, you will ask them to give the diazepam, and you make intramuscularly 2 milliliter of the diazepam, and of course call the ambulance. As you see, milliseconds, 10 seconds, and 2 minutes. It's very short period of time, and to this time ambulance did not come. So you must help such a person. Don't be afraid. It's not frightened situation for you, but you just may uh, give him the first aid and help such a person. Now, good luck. I wish you big success in your future profession, and it was the neurology lecture.